Okay, so when we speak about the amylase, it can be both secreted from the parotid gland and also from the pancreas. Okay,
Yes.
so this is breaking down. Just forget about this page. I'm just telling you like an overall view of all of the digestive system. Then we will start reading them one by one, and it will make sense. So,
Okay, doc.
okay, so the carbs was destroyed. Excellent. It becomes from disaccharidase, it become the disaccharide into monosaccharide. Okay?
Got it, doc.
So disaccharide was like two glucoses binding to each other. Now we have monosaccharide, one glucose by himself. For example, glucose, galactose, or anything. So anyway, now we have done with the bread. Put it aside. Now we have meat. Yes? What
Yeah.
is meat made out of?
Proteins, doc.
Excellent. Proteins, well, they are cells. Meat are cells, yeah?
Okay.
Cells of animal. But so they have a nucleus and they have cytosol with a lot of proteins in it, yeah?
Okay.
So the cytosol is going to give us a protein, but the nucleus is going to give us a nucleic acid. The nucleic acid is going to undergo the purine salvage pathway, which eventually is going to give you uric acid, yeah?
Okay, doc.
While the proteins give you amino acid, yeah? Because proteins are made out of amino acid, right?
Okay, doc. The nucleus has what, doc? I'm sorry.
Nucleic acid material. Well,
Nucleic acid. Okay.
yeah, you remember nucleotide?
Nucleotide, yeah, doc. Base, ribose sugar, and phosphate group.
Excellent. So this is basically because it's annoying to say nucleotide and nucleoside, DNA, RNA, all of these go under the name nucleic acid. Okay?
Okay, doc.
It's just like a general name. Like our food is consist of carbs, protein, fat, nucleic acid. Good? So four
Okay, doc.
things. Okay, so from the amino acid, we can get something called ammonia as a byproduct, of course.
Okay, doc.
Ammonia can become urea. Where?
Ammonia is converted to urea in the liver, doc.
Done. Urea cycle. Good. So we ate that steak. Now it's gone into our mouth. Nothing to help with it. So it's just going to go to our stomach. Yes?
Yes, doc.
Inside of our stomach, it's full with amino acids, of course. So the amino acids are going to stimulate the stomach and be like, hey, there is meat here. So the stomach indirectly will start to secrete acid. The way it started to secrete acid, that it stimulates something called the G cells to produce the gastrin. Okay? This
Okay.
gastrin go to the blood, and after it goes to the blood, the secretion of hydrogen starts. Okay?
Okay.
Okay. All makes sense so far?
Yeah, doc. So the new amino acids, basically they activate the gastrin, and gastrin produces hydrogen.
Yes. It's not only these that activates it. There is multiple things that can activate gastrin to be released. Let me tell them for you. One. Oh, actually, it's written here. So if you eat something, you will have stomach distension. Yes?
Yeah, doc.
If you alkalinize the stomach, that means like regardless of how acid the thing you ate, your stomach is more acidic. The acidity of stomach is like 2 or 3 on the pH, yeah?
Okay, doc.
So whatever you eat, even if it was acidic like 4 or 5, that is considered alkalinization of the stomach, yes?
Okay, doc. Yeah.
So it's still going to secrete. Amino acids also are like amino acid and peptide, meat basically, is going also to stimulate it. Now this one is important. Vagal stimulation via gastrin released peptide, GRP. Let me explain this one. You know when you see really, really delicious steak and you are looking at it?
Cephalic phase. Yeah, doc.
Absolutely, the cephalic phase. You start wanting it, and your vagal stimulation start telling your stomach, prepare yourself. This guy is going to eat something big. You need to be prepared. Yeah?
Okay, doc.
Yep. So that's how it works. So vagal stimulation via gastrin releasing peptide, the GRP. So instead of using acetylcholine here, they use something called GRP. Do they use the muscarinic receptor? The answer is yes, but that is for a little bit later. Don't worry about it now. Okay? So
Okay.
basically...
But doc, nowhere over here it's saying anything about mouth, right, doc? This is all when the food enters the stomach,
Yeah,
right, doc?
that's why I told you about the mouth, because it's not
Okay.
written. So you can see here the vagus nerve. Which cranial nerve is it?
The vagus is thin, doc.
Where it originated from?
Vagus originated from, it says the brainstem from medulla, doc.
Absolutely correct. Nice. So the vagus have so many like portions. One of them is the one that we care about, at least for now. It's this one. Yeah. So GRB, gastrin-releasing peptide, will stimulate the G cells to produce gastrin. There is two mechanisms in which the gastrin will lead to secretion of HCl. Yeah. Remember, the HCl function was to destroy these proteins and to help with the digestion. Not only HCl can also go and cleave the pepsinogen into pepsin. Yeah.
I didn't know, doc.
Well,
So, gastrin will go and what is it going to do, doc? Break down the food, HCl?
gastrin is going to stimulate the parietal cell to produce HCl. HCl is
Okay.
acidic. Yeah. So
Yeah, doc.
remember when I told you we cut the N terminal and the C terminal and this stuff?
In protein, yeah, doc.
Yes. So this HCl, for example, is going to pepsinogen. It's going to cut its N terminal and C terminal and convert pepsinogen into pepsin. Okay?
Okay, doc.
This pepsin is going to help us break down the B proteins. Okay?
Okay, doc.
Okay. Don't worry, man. The GIT is an interesting system. We know so much about it that it makes it easy. Everything makes sense in it. Okay?
Okay, doc.
It's not like other system in which like it is what it is, you know?
Okay.
But yeah, here there is a lot to understand. So, okay. So they also say that sometimes it can decrease in function, the gastrin. I mean less gastrin. Less gastrin mean less HCl, correct?
Yes, doc.
So when it decreases, when the pH in the stomach is less than 1.5, if the pH of the stomach is less than 1.5, it means that the gastrin already made the stomach super acidic. Should he make it more acidic? The answer is absolutely
doc.
not.
Ulcer.
Yep. So let me tell you a little bit about it. So it's from G cells, which is mostly located in the antrum of the stomach. Now, this is no joke. You have to tell me about the portion of the stomach. Ah, shit,
Yeah,
it's
doc.
written here. Because here you need to know them. So,
Yeah, doc.
okay, let me just draw a stomach really quick. 1, 2, 3, and 4, and 5,
So,
and 6, and 7. No, enough. Okay. Okay, so 1, 2, 3, 4, and 5, and 6.
one is fundus, doc. 2 is cardia. 3 is body. 4 is from 5 is pyloric sphincter, I guess.
So this
4
is
is antrum.
antrum.
5 is pyloric sphincter, and 6 is duodenum.
Okay, done. Good. So the 4 is antrum, yeah?
Yeah, doc.
Okay. So antrum of the stomach have the G cells, also the duodenum. Okay. So the action, we said what stimulates it? Corona, bro?
No, water. It just went into mine.
I see. Everybody here have corona. So, oh yeah. So gastrin will lead to increased release of gastric hydrogen secretion. So we'll have more gastric hydrogen secretion, which is basically the HCl. Yeah.
Yeah, doc.
Also increase the growth of the gastric mucosa because it needs to protect against the acidity of the lumen. Look, the function of the gastrin is to make the lumen acidic, not the walls. The walls must stay alkaline. Yes.
Okay, doc.
And the thing that keeps them alkaline, there is multiple things, but one of them is the mucosa. Okay?
Okay, doc.
Increasing gastric motility as well. Okay?
So basically, it's just trying to do its function, also protect the stomach, right, doc?
Correct.
It is producing more HCl, but it's also increasing the gastric mucosa to make the walls tolerate it, and it's trying to get the food out so that it doesn't stay for long and cause any ulcers.
Absolutely correct. Now, these notes are super important. They say it increases with chronic PPI use. You are like, why? Well, when we speak about PPI, proton pump inhibitor, they block this area. Yeah.
Yeah.
So when they block this area, we will have negative feedback type of thing, be like, oh, there is no acid in the stomach, gastrin, be released. Why?
Oh,
Because
yeah.
a proteins pump inhibitor is decreasing the acidity. That means the pH will be higher. Yes?
Got it, doc.
High pH of the lumen make the gastrin release more. Yes?
Yes, doc.
All makes sense?
Yes, doc.
Okay.
So the acid will be more, doc?
The gastrin would be more, not the acid.
So-
Acid is inhibited by the BBI.
So in that case, the mucus probably will be more, doc?
Yes, absolutely. The mucus
Growth
will
of
be.
mucus. Okay.
Yep. Okay, by the way, just there is so many things that can do them, but just take it one at a time. Don't take them all together because you get confused. Okay?
Got it, doc. Yeah.
So yeah, now we are just worrying about the gastrin. It's the only thing that we worry about for now. Okay, so a few more things about gastrin. Here they say increasing chronic atrophic gastritis due to H. pylori. I want you to understand this. This is just take a moment, but it's important. Actually, personally, I'm becoming in the future either a cardiologist or a gastroenterologist or a nephrologist. That's why I went to internal medicine. That's because I love these three subjects. Yeah, so we'll see.
So you covered all three with me, right, doc?
Oh, well, let me see.
Now
Yeah,
you finished cardiology with me, renal with me, now GI.
yeah, and neurology. But neurology, well, I had a good chance of matching in neurology, but man, their salary in the US is like much worse than internal. I don't know why. So yeah,
Yeah.
internal it is. Okay, so you can see here the stomach. Let me take a portion from here and make it much larger. Okay.
Yeah.
So now it's like this. This is the one line, okay? It's this, like the whole wall. Okay, so the wall will be, this is the lumen, yeah? And this is, well, the outside, the serosa of the stomach, yeah? So we have layers. We have mucosa, submucosa, muscularis, serosa, yeah? So
Yeah, doc.
mucosa.
One second, doc. I think we did that topic, right, already? The layers.
Yeah, of course we did.
The mucosa, submucosa, muscularis, and serosa. Yeah.
Yep. So now I can add a few more things. Well, I'm going to explain for you why we get ulcers. We keep saying H. pylori causes ulcers, H. pylori causes ulcers, H. pylori causes... But why? Well, can you see the H. pylori? I'm drawing it. Where it is located? Is it...
Between the mucosa and submucosa.
So it's not in the lumen, yeah?
No, yeah.
So some of it, actually, it comes from the lumen, but it penetrates the wall and reside under the mucosa, okay?
Okay, doc.
So when it's here, this evil guy, what he started to produce, he started...
Urease.
Exactly. What does urease do? Make urea into ammonia, yes?
Okay.
This guy is going to lead to local alkalinization of the mucosa, yeah?
Okay.
So this area is going to become alkaline. You're like, okay, so, well, if this area becomes alkaline, who detects that? Gastrin, okay?
So, doc, why is it getting alkaline, doc?
Because, let me show you this urease activity. So there is something called urease reaction, okay?
Okay.
And it goes something like this. Hopefully I will find it. Just a momento. Okay. Okay. So here is the urea with a lower pH, okay? Then, so see here they write urea with a low pH. It gets this reaction, okay? And it's converted to something else, which is what? Ammonium. But this ammonium is still an acid, but it's a little bit more alkaline than urea, okay?
Okay.
I really cannot find a good picture of it.
So you're saying the ammonia is what makes it more alkaline?
Yeah, because if you notice
Okay.
here, notice, urea has how many H's?
Urea...
4.
4, doc?
Yes, 4. While ammonia,
I see. Okay.
3. So it's much more alkaline. So we say that it can precipitate to alkalinization of the mucosa of the stomach. So who's going to detect that? Gastrin. What gastrin is going to do? He will go to the parietal cells and be like, parietal cells, damn it, you are alkaline. Start producing HCl for me. Yeah?
Okay.
So that will lead to hyperacidity of the lumen. Yeah? But wait a
Okay.
second. The lumen is acidic, but the submucosa is still alkaline. So what will happen here? It's a cycle. Yeah?
Yeah.
Boom, 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 until the acid is going to destroy the wall. That's an ulcer. Yes?
Yeah.
Does it? Can you repeat for me, please, how an ulcer happens because of H. pylori? Just what you understood.
Yeah, doc, sure. But one question, doc. Where is gastrin present, doc, in the stomach?
Well, it's mostly comes from something called the G cells, which is located mostly in the antrum of the stomach and also in the duodenum.
Yeah, but I mean the layer-wise, doc, like
The G
mucosa,
cells.
submucosa.
Yeah, well, you were asking which layer is it secreted from? Yes?
Yeah, doc. Usually, where are these in the?
It's if I'm not mistaken, I'm sure it's the submucosa, but let me just confirm that. Let me just confirm it. It's the submucosa for sure, but one second.
Okay.
So-
For you to detect the alkalinization of the urea, doc.
Yeah, okay, yeah, absolutely, yeah. It's the submucosa layer, okay? It's all of the secretory stuff, like the ones who secrete gastrin, and the cell that secretes the HCl, but it is not secreted outside. It has a ductules that secreted in the stomach. All of this stuff are located in the submucosa mainly, okay?
Okay. Now, what made you say that, doc? Like the submucosal
Well,
nerve plexus?
because even in the respiratory tract, the secretory cells are in the submucosa. GIT, it's in the submucosa. You know, like it's everywhere.
Okay. Doc.
Like all
Awesome.
system, it's always the submucosa. So that makes me
Okay.
always think, okay, it's that one. But I just need to confirm. And then, yeah,
Got
it
it,
is.
doc.
It is. Okay.
So I'll tell you how ulcers are formed, doc. So basically, we have a lot of H. pylori in our stomach in the submucosa part of the cell of the layer, and that's where the H. pylori resides. H. pylori secretes urease. Urease is a substance which converts urea into ammonia, and when it converts that, it becomes more alkaline because urea has 4 hydrogen and ammonia has 3 hydrogen. So relatively, it's less acidic. So basically, it's alkalizing the layer, and gastrin detects that and produces more and more acid, thinking that it's more alkaline because it also is in the submucosal area.
Nice.
That's it, though.
Yep, absolutely. Well, now you can also understand why they can lead to gastritis. Same exact mechanism. Yeah?
Yeah, though.
Okay, makes sense?
So, but doc, why is H. pylori? They say it's a probiotic, right, doc? No.
H. pylori. Wait, what?
Is it good for the stomach or bad for the stomach?
No,
doc?
it's horrible, man. H. pylori is
Horrible,
horrible for our stomach.
So,
Probiotics.
what is this probiotics, doc? Like
Yeah, that's something else. So the probiotics,
okay.
basically we have normal flora, but it's not in the stomach. It's actually located in the big intestine. Large intestine,
Oh,
which is the colon. These
Okay.
are good for us. They help us to make vitamin K. They help us to make some vitamins. They help us to not get the Clostridium difficile infection, you know?
got it, doc.
Even, I know why you are thinking about this. You read somewhere that the treatment with H. pylori is done by triple therapy, yeah? After
Yes,
triple therapy, the patient can get a Clostridium difficile infection. Why? Because he kills his normal flora. Killing the normal flora gives chance for the Clostridium difficile to thrive. Okay? So you will have plenty of Clostridium difficile. Well, how to treat it? You can give metronidazole, you can also give vancomycin, but eventually you have to give probiotics. Okay?
Okay. Doc.
Got
So,
it?
doc, after biochem, we do the cellular biochemistry, right, doc?
Yes.
Next, we have lab techniques, right, doc?
After yeah.
Before starting the lab techniques, doc, can we do the first part of the micro and then go back to lab techniques?
Actually, that's really smart. Yes. Because I want you to start making on your own sketchy, man.
Yes, doc.
Okay.
Make my own sketchy?
No, no, no. Like, I mean, in your own time, I want you to watch a sketchy, and I can, like, for five
Oh, yeah.
minutes each day, like,
I know,
test you
Doc.
really quick on it. You know?
I know, Doc. Yeah, Doc.
Good. So here we have something called Lingard-Ilson syndrome, which is also known as a gastrinoma. It's a tumor that secretes plenty of gastrin. Okay? So
Okay,
if it secretes plenty of gastrin, there will be a lot of HCl. A lot of HCl means a lot of ulcers. Yeah?
Got it, Doc.
Make sense?
Yeah, perfect.
Okay. Somatostatin. He's the badass guy. He's Dr. House. My ex used to say, he's me. Well, let me show you. What does it mean? Well, Dr. House. So when Dr. House, you know Dr. House, yeah?
Yeah.
Okay, when Dr. House come, everybody shuts up. So what do I mean by that? That's somatostatin. It's Dr. House. He's a dick. So he comes from the D cells, yeah?
Oh, okay.
Yep. I don't know why my ex used to tell me you are somatostatin. Anyway, so it decreases the secretion of everything. Yes?
Got it, Doc.
So notice, when somatostatin comes, it comes from the D cells, you know why? And these D cells are located in the GI mucosa and also in the pancreatic islets. So what is the function of somatostatin? Well, basically, somatostatin is some type of an analog of what? Growth hormone. Yes?
It's an analog, Doc? I thought it shuts down.
I'm sorry. Somatotropin. Okay, so this just blocks it. Yeah?
Yeah, Doc.
Okay. So it decreases gastric acid and pepsinogen secretion. Done. So less of these. Pancreatic and the small intestine fluid secretion, reduce it. Gallbladder contraction, no need. Insulin and the glycogen release, why to do that? So he comes and turn everything down. So why would he do all of this? Okay? So the reason he will do all of this is when the acidity of the stomach is really, really high. Well, why? Because actually, it's not the stomach, it's the duodenum. If we say the food was in the stomach, okay? And he moved to the duodenum, yes? He's in the duodenum now. And you finished the whole digestion thing, okay? And now the environment here is really acidic, yes? Would you like the stomach to keep working?
No, Doc. Take rest.
Yes, take rest. The secretine is better for that, but wait a second. The whole food went outside. It's not in the duodenum anymore. Actually, they should put secretine here and somatostatin down, but it's okay. So the food is out, like it has moved forward. It's done with the stomach. It's done with the duodenum. So because it's done with these two, but the environment is really acidic still, we need to turn off all of the digestion function, correct?
Yeah.
How to turn it down? Boom. Yes? With
But
somatostatin.
this is only for the stomach and duodenum, right, Doc?
Yes, that's correct. Stomach and the duodenum. So, well, small intestine as well, but I hope you get it. It's like after you eat for some time, somatostatin is down. After you ate and you have digested your food and you are going to poop it, no need for stomach and like the duodenum to work anymore. So we need just to turn them both off, okay?
Got it, Doc.
I'm insisting in the word both because there will be something else that turn off only the stomach and keep the duodenum on, for example. Okay?
Okay, Doc. Got it.
So it's increased by acid, decreased by vagal stimulation. When we have vagal stimulation, means we need to work. We need to digest. Yes?
Yeah.
Remember, vagus, rest and digest. So when he's working, we need to do the job. When it's not, we cannot do the job. So when vagal is present, somatostatin turns down. So it inhibits the secretion of various hormones, and octreotide, it's an analog of this guy. It can be used to treat acromegaly. Because why? Because it's an inhibitor of the somatotropin, correct?
Inhibited the somatotropin. Okay, Doc.
Also for carcinoid syndrome, because it inhibits the secretion of serotonin, okay?
Okay, Doc.
For VI BOMA, because it inhibits the secretion of VIB, okay? And for Verisial bleeding, which we did not speak about Verisial bleeding yet, but it's basically these patients who have like a connection in their esophagus, you know, hepatic cirrhosis, After hepatic cirrhosis, they start to have portal hypertension. Portal hypertension start making connection in the esophagus, which lead to esophageal varices. Yeah? It's a topic we are going to speak about more deeply in the near future, actually, in GIT. But do you have any idea about this topic in general?
Yeah, doc. Like you know how we have those connections of you told me the esophagus varices between the left gastric and esophageal vein.
Absolutely, the
The
portocavity.
zygos. Yeah.
Yeah.
So during portal hypertension, I know this happens and we have hemoptysis because of portal hypertension.
Well, is it lethal?
Very little, doc. We lose a lot of blood, right?
Yes. Almost, we say like 25 until 40% of the patient dies from this. Okay?
Yeah.
Good. So, okay, done. So here we have the next thing. We have verisial bleeding, done with this one. Okay, so the next thing. Why verisial bleeding, by the way? Because somatostatin can lead to local vasoconstriction in the esophagus when you swallow it, which can lead to stoppage of the bleeding. Okay?
Okay.
Can you repeat this point? It's important.
It is going to call vasoconstriction, you are saying, right, doc?
Yeah, in the esophageal veins, which can reduce
Which
the
can stop the bleeding.
Yep, absolutely. Good. So let's just speak about the next one, which is cholecystokinin. Oh, yeah. Okay. First of all, I hate to explain this one without dissecting the name. Coli. What does coli mean? Bile.
Bile. Yeah.
Cysto is the gallbladder. It's like a bladder. Yeah. It's we say cystoscopy, for example, which is a scopy of the bladder. Yeah. So cysto means a sac. So here we are speaking about the sac for the bile. So it's the gallbladder. Yeah.
Got it.
So kinin, it contracts. Okay. Cholecystokinin. Cholecystocontract. Okay.
Yeah.
So this hormone is going to contract the gallbladder. Actually, it will do more than that, but yeah. So far we spoke about G cells and the D cells. Remember, D cells. Dr. House, he's a dick. Okay, so the next one, cholecystokinin, it comes from the eye cells. Okay. So these eye cells are located mostly in the duodenum and the jejunum. Now the question will be why? Well, look. When you eat the food, it goes to your esophagus, then to your stomach, correct?
Yeah.
The pylorus is shut down still, correct?
Which pylorus is that?
Pylorus sphincter. Okay. It's shut down.
Yeah. Okay.
I suck at the drawing stomach. Just imagine it as a stomach, okay? So
yeah,
the food is here. After some times, you did what it did with it. This guy is going to relax, yes?
Mm-hmm.
When he relaxes, you are going to have the food moving into the duodenum, correct?
Okay. Yeah.
So the food now in the duodenum, you need to separate the two stages of digestion, which are the gastric stage and the duodenal stage, okay?
Okay.
The gastric stage is done. Now it's time for the duodenal phase and the small intestine phase to occur. Who initiate that? 2 hormones. Actually 3. Anyway, for now, I want you to know about cholecystokinin. Also, secretine help with it, but now just cholecystokinin. So the eye cell. So the eye cells, which are present in the duodenum and the jejunum, when they detect amino acids and fatty acids in the duodenum, they start to function. Okay? When there will be fatty acid and amino acid in the duodenum, when the stomach expel the food into the duodenum. Correct?
Got it.
Okay. So, there will be an increase in the pancreatic secretion. Okay.
Mm-hmm.
Also, why? Because we need digestion in the duodenum, and we know that we have a pancreatic duct and we have a bile duct that goes to the duodenum. We need to make both of them functional. Yes.
Mm-hmm. Yeah.
So pancreatic secretion high. Check. Gallbladder contraction. Well, the hormone name is cholecystokinin. Yes.
Yep.
Check. Gastric emptying is decreased, so we block the Baloric Sphincter. Yeah? Why? Because you want to separate the gastric phase from the duodenal phase. Why? Because the gastric phase is super acidic. The duodenal phase is super alkaline. So you don't want them to work together. You know?
Okay, doc.
because it will not make sense. The stomach can break some stuff, and the duodenum can break some stuff. You cannot just make the both of the system work together. So
Got it.
it decreases the gastric emptying, and also it increases the sphincter of OD relaxation to allow both the pancreatic juice and the bile to flow into the duodenum. Make sense?
Got it. Yeah, doc.
So it acts on acts on neuronal muscarinic pathway to cause pancreatic secretion. So now the question is like, okay, I got it, like it leads to gallbladder contraction. What about the this pancreatic secretion thing, you know? Well, basically this cholecystokinin, can you see it here from the eye cell in the duodenum? It can come,
Yeah,
and I hope we have a picture of the pancreas. I don't remember if we have one. We don't. Well, basically, it will go to the pancreas and it will promote the secretion of of pancreatic juice from the pancreas in an endocrinological fashion. Oh, by the way, just for the sake of explanation, gastrin, somatostatin, cholecystokinin, secretine, GIB, motilin, VIB, nitric oxide, and garlin. Man, I want you to know that all of these hormones are endocrinological hormones. What does that mean? They are released into the blood, not locally.
locally.
Not locally, into the blood. Okay?
Okay.
Got it? So
Exocrine is in the
exocrine,
duct
it's
locally.
locally, like lipase, for example, amylase. Yeah? These are exocrine because they are produced locally. Yes? And secreted.
So these are all endocrine, doc?
All of these are endocrine. Yes. If we speak about amylase, lipase, elastase, these are secreted using a duct. Anything that is secreted using a duct, that's exocrine. Okay?
Yeah. Doc.
Anything that is released into the blood, that's endocrine. Okay, so the next thing we have is secretine. Well, I was waiting for this guy. Secretine comes from the S cells. Do not confuse S cells with the D cells. D cells give us what?
The somatostatin, tick.
Yeah, because both of them starts with an S. People tend to confuse which one comes from what. Just remember, somatostatin is Dr. House. He's a dick, so he inhibits everything. Okay?
Got it, doc. Yeah.
Secretine. It comes from the duodenum. It increases the bicarbonate secretion, which makes the duodenum really, really alkaline. Yes?
Got it.
And decreases gastric acid secretion and decreases bile secretion. Again, the secretine and cholecystokinin, both of them are trying to do what?
The increasing the bile, doc.
Increasing the duodenal phase and inhibiting the gastric phase. Yeah?
Yes, doc.
Okay. So the next thing is going to be the regulation of such a procedure. So the secretine, there will be increase by acid and fatty acid in the lumen of the duodenum. When they see the fatty acid and the amino acid in the lumen of the duodenum, they are like, okay, we need to start secreting this guy to inhibit the stomach and start the duodenal phase. Because already we have the food. Yes?
Yeah, doc.
Okay. I hope GI so far is making sense.
Yeah, doc.
It's a lot, I know.
But I'm going to read it after a class and I'm going to shoot you with questions tomorrow.
It's
Right
actually,
now, I'm just listening to everything. Yeah.
yeah, it's really, really interesting topic. Let me just, man, you're making me obsess about this recording thing. Keep checking it. So, if we speak about the next one, which is secretine, it increases the bicarbonate that neutralizes the gastric acid in the duodenum. We established that. We said the gastric acid, when it mixes the duodenum, this hormone starts to be secreted, which will lead to pancreatic bicarbonate to be released, which is going to lead to increased bicarbonate secretion. In the future, I'm going to describe for you how exactly the pancreas is making this bicarbonate. Yeah?
Mm-hmm.
And what other substance does it contain in it? And the relationship with cystic fibrosis and the chloride channel. All of these will be in the near future.
Okay, doc.
So allowing the pancreatic enzymes to function. Okay, so for pancreatic enzyme to function, they need what? An alkaline environment. Okay?
Yes, doc.
Okay, the next one, GIB, or glucose.
Doc, one question, doc.
Uh-huh.
We have pepsin, we have amylase, we have trypsin. These are all proteins, right, doc? They digest proteins, right, doc? All these things.
Well,
But-
yeah.
So the pepsin is all stomach, right, doc?
Again,
And
did not hear that.
the pepsin only works in the stomach, right, doc? The pepsin
Okay.
to break down proteins.
Yes.
But in the duodenum, we have amylase and the trypsin, right, doc, for it to break down proteins.
We have chymotrypsin, we have a trypsin, we have a proteases, we have lipases, we have a trypsins. So all of these guys, wait for it. We are going to
No,
reach
just for protein, doc. Just for protein.
proteins. Okay, proteins in the
Yeah.
stomach. It's going to be the pepsin. Okay, HCl as well help to break down the proteins, but not as good as the pepsin. Remember, the pepsinogen was converted to pepsin with the
By
help.
HCl.
Yes. So that's why we can say that HCl is a major helper of that. Okay.
You said it cuts the N-terminal and the T-terminal of the
Pepsinogen
protein, doc?
of the pepsinogen to make it pepsin. Yeah.
Oh, okay, doc.
Okay. So also
Got
in the duodenum, we are going to have these enzymes: trypsin, chymotrypsin, elastase, carbopeptidase. All of these are types of proteases that help digestion of the protein. Okay.
Okay, doc. Okay, doc.
Good. So let's keep going with the VIB. GIB. GIB from the K cells. K. So K cells located in the duodenum and the jejunum. They have exocrine and endocrine. What is the difference between exo and endocrine, please?
Exocrine is locally through ducts, endocrine is through blood, and which is systemic.
Yep, that is correct. Good. So K cells, exocrine decreases the gastric hydrogen secretion, gastric acid secretion, and endocrinologically increase the insulin release. Let me tell you a story. You have a patient and you give him glucose intravenously, and you have his twin brother. Who has the exact same physiology as him. For patient 1, you give him the glucose orally. For patient 2, you give the glucose IV. Okay? Which one is going to have more insulin level after glucose got into his body?
Definitely oral because they have GLP and GIP, though.
Absolutely. So the GIP, because when the glucose is taken orally, that will increase the GIP, which lead to this. Make sense?
Got it.
Awesome. Okay, so let's take a look at the next one. They write increased by fatty acid, amino acid, and oral glucose, also called gastric inhibitory peptide, GIP. Oral glucose load increased insulin compared to IV equivalent due to the GIP secretion. Make sense?
Yes, sir.
Okay, so the next one is mutulin. Mutulin help to move the intestine. Well, let me tell you a story. I have a family member, he's diabetic, okay? And he had this it's not pain. He did not feel any pain because of the neuropathy, polyneuropathy. He did not feel any pain in his stomach. But he kept saying that after he eats, he feels the urge to vomit, and he does vomit. So many times.
Bulimia?
No, he's not bulimic. But he eats, and then after he eats, he just sit down. If he eats something else, he cannot hold himself, and he wants to vomit. Actually, you said bulimic, that's what I thought, but it was wrong.
Okay.
So the next time, eventually he went to the doctor. The doctor requested him to do an endoscopy, okay? So he ate his last meal at 4 p.m., okay? And his endoscopy was at 4 p.m. the next day, so 24 hours without food, yes? When they did the endoscopy, they could not, finish it. Why? Because his stomach was full with food.
Oh.
What is your diagnosis?
Less peristalsis, so low motilin, doc.
Not motilin. It's gastroparesis, okay?
Oh, is diabetic, though?
Yes, diabetic. Gastroparesis, and that's the reason why it's his stomach was not contracting, because polyneuropathy, the stomach is not contracting. Yeah. So how can we help him? Well, there is a receptor called mutulin. Okay. This mutulin receptor, when you stimulate it, it's going to lead to motor activity. Okay.
Okay.
And that is going to help to move the intestine. So that's exactly what they did. So the mutulin receptor is located in the small intestine. It produces migratory motor complexes, which is basically the contraction of the stomach, the peristalsis. Okay?
Stomach doc or the intestine doc?
Intestine. But actually, to be fair with you, it's not only in the small intestine, it's also located in the stomach, this receptor. I deeply went into this receptor. That's why I know a lot about it. So,
Okay, doc.
increase in the fasting state. That's why when you are hungry, what your abdomen start to do, make this sound, yeah?
Mm-hmm.
That the sound that keep embarrass us in the public. It's because of mutulin, okay?
Okay. Basically, peristalsis, right, doc, is increasing.
Yes, absolutely. So mutulin receptor agonists such as erythromycin. Wait a second. What is erythromycin?
Antibiotic, doc, macrolide.
Yes, but it still have an activity on the mutulin receptor. So we use it to stimulate the intestinal peristalsis, especially in a patient with gastroparesis. Okay?
Okay, doc.
All make sense?
Yeah.
Okay, let's go to VIB. So vasoactive intestinal polypeptide. This guy is produced by the parasympathetic ganglia in the sphincters, gallbladder, and the small intestine. Well, what is the idea of this VIB? Well, VIB, main idea that it can lead to secretion of a lot of water into the intestine and electrolytes, okay? And it can help. It's, a VIB person does...
Yeah.
if you are a VIB person, will anybody close the door in your face or everybody will open the doors in front of you?
Open the door. Doc.
Yes, so the VIB opens all of the sphincters of the body, okay? I mean, of the GI. Good.
Doc, can you just explain to me the sphincter innervation, like in the GIT, doc?
Absolutely. So,
And different sphincters in the whole GIT from mouth to anus?
well, okay, I will tell you them. I will tell you where they exist, and I will note for you what is high yield and what is low yield, okay?
Okay, doc.
So, because some of them are just completely useless to know, but some of them you must know. So, if we speak about the first sphincter we have our upper esophageal sphincter, okay?
Okay, doc.
Low yield. We have our lower esophageal sphincter, super high yield. Yes? Why?
Got it,
The esophagus, GERD, stuff like that. Yes?
Yeah.
Okay. Now, next we have our Baloric Sphincter, high yield. We can have hypertrophy of the Baloric Sphincter. Yes?
Yeah, doc. Yeah.
Okay, the next one. Heliosical Sphincter.
Heliosical sphincter. Heliosical.
Between the ileum and the cecum, so between the small and the large intestine. Yes?
Yeah, doc. Okay, doc.
The anal sphincter.
Yep.
Okay? And there is, to be fair with you, there is like inside of the esophagus, okay? Oh my God, that does not look like an esophagus. Anyway, inside of the esophagus, there is 5 sphincters, okay? 5 physiological sphincter, we call them, and 3 anatomical sphincter. You don't have to know any of them except one. Which is which one?
The lower esophageal sphincter.
That's it. Anything else is just waste of your time.
Okay.
So, so VIB.
No, I just want to know the nerve innervation. Is it parasympathetic or sympathetic like that?
Always parasympathetic. Okay, of course.
So parasympathetic is making it open or closed, no?
Open. Remember, the parasympathetic helps us to digest, so it needs to open it. Yeah?
It needs to open it. Okay.
So, increase in the intestinal water and electrolyte secretion, increase relaxation of the intestinal smooth muscles and the sphincters. Okay? So, when do we have more VIB? Well, when you have more vagal stimulation and more distension. Yes? Which means there is food inside. So, you need to deal with it. Open the sphincters for it. Make it move. Put water inside of it so it will move. Yes?
Yeah, no.
So, the water, we put it inside of the chymos, we call it. Digested food, we call it chymos. So,
Doc, basically the sphincters are open, but it also does the contraction of the so that the food will move forward.
No, that's mutulin. The idea of this guy is like you have a tube, and you need to move something through the tube. So you open the sphincters, and then you push a lot of fluid inside. Why? To flush it. Yeah.
Yeah. No.
So that's what it does. It increases intestinal water and electrolyte secretion to flush the chymos or the food forward. Yes?
Okay.
So it
And
decreases
Doc, you said intestinal water is morely done in the large intestine, right? Doc? The water reabsorption.
the water
You were telling,
reabsorption is
you were
mainly in
talking
the
to me
colon.
about the fissures, anal fissures, and you said when we don't a stool, the large intestine is the place where the water is being reabsorbed a lot. So that's why it becomes very constipated very soon if you don't regularly have bowel movements. Like
Absolutely, yes. So it was that boy who does not go to the toilet. So his
poop,
his
yeah,
poop
and
is inside
the
of
more
his.
time it stays in the large intestine, the more water is reabsorbed and the more harder it gets.
Uh-huh.
Right, though?
Yes. Okay. Nice.
Okay.
Okay, good. You remember that point. Do you remember what is exactly the anal fissure will be most likely?
The anal fissure most likely will be below the pectinate line, though, dentate line.
Yeah, but is it anterior or posterior?
Usually posterior, though,
Why?
because less blood supply in that area.
Excellent. Good.
Less nerve supply or blood supply, though?
Blood.
What was it?
The blood supply.
Okay.
So poor healing. So VI boma, non-alpha and non-beta islet cells pancreatic tumor. So it can be from a pancreatic tumor, which is something they don't mention here. Here they say blah, 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 blah. None of them say pancreas. You need to add pancreas here. So the pancreas can also be produced by the, VIB can also be produced by the pancreas. And the tumor in the cells that produce the VIB will lead to something called VI boma. So that can lead to Whatha syndrome, WDHA. So watery diarrhea, hypokalemia, okay? Why? Because they secrete, first of all, why watery diarrhea? Because I told you one of its function was to secrete water and electrolyte, yes? So,
Secret, okay.
yes, so the patient is going to get watery diarrhea,
Diarrhea, yeah.
hypokalemia, and achlorhydria. Do you know what achlorhydria mean?
Yeah, this chloride also is gone, though.
Yep. Okay, makes sense?
Yeah. Hyperchloremic, hyperkalemic, metabolic alkalosis, though, vomiting.
Again, please.
Vomiting causes hyperchloremic, hyperkalemic, metabolic alkalosis, right, though?
Wait, man.
Vomiting.
I think you are misunderstood achlorhydria. What does achlorhydria mean?
Loss of chlorine, though.
No. Okay. So that's hypochloremia. Okay. But achlorhydria is decrease in the HCl. Okay. Hydrochloric acid.
Oh,
Okay.
this is not chloride. Okay.
No. It's HCl. Okay.
HCl. Okay, though. Thank you.
Good. So that's Whatha syndrome. Good. So let's speak about the next one, nitric oxide. Wow, this page is loaded. Yeah. Nitric oxide can lead to increased smooth muscle relaxation. Can you tell me how?
Yeah, doc. Nitric oxide basically converts GDP to. It basically it does the MLS this thing, right, doc? Kinase.
Well, nitric oxide is going to lead to more activity of something that is going to lead to smooth muscles contraction.
Why is the relation? Yeah,
No,
nitric
not
oxide
contraction,
is going
relaxation.
to convert GTP to CGPMP, which will increase MLC phosphate and relaxation.
Yep, that's it. Okay, so including the lower esophageal sphincter. So the nitric oxide relaxes the sphincters, especially the lower esophageal sphincter. The loss of nitric oxide secretion is implicated in increased lower esophageal sphincter tone. It will become contracted so much. Why? Because no nitric oxide to relax it. So that can lead to achalasia. Yes?
Achalasia cardia. Okay, doc. Yeah.
Okay, good. Garline. Garline is produced by the stomach, and it's produced when you are hungry. Okay? So this is important. This is super important, actually. So it's produced by the stomach. If you look at the stomach here, it's mainly produced by the fundus of the stomach and the corpus of the stomach. Okay?
Mm-hmm.
Have you ever heard about a surgery called the sleeve gastrectomy?
Yeah, doc.
So we remove this portion of the stomach in it, yeah?
Yeah, doc.
So the appetite, the garline is produced from here. So what will happen to the appetite of the person after removing this portion of the stomach?
Very less, doc.
Make sense?
Got it, doc.
So, increase in the fasting state decreases by food. It increased in the Prader-Willi syndrome. This is why these patients are fat, and we'll speak about them in the chapter of in the genetics. And it decreases after gastric bypass surgery. Make sense?
Doc, there's ghrelin. Where is it present, doc? You said?
In the fundus and in the corpus of the stomach.
You said corpus?
Corpus, body.
Oh, body. Okay.
In Latin, we say about body, corpus. Okay?
Okay, doc.
Okay, man. So let's take a break for now. And wow, that page took an hour. Okay, so let's, it's actually a good page because, now this will be speaking about it for the rest of physiology. So it's not a waste of time. It was a really good investment. So
you want to upload this, though?
good. Nice. So let me upload it right away.